This is session 2, glaucoma and diabetes.
Can you all see my screen?
Yes.
Yeah.
That's good.
Okay. So I looked at all the diabetes past paper questions, and I found that most of the questions were based on the clinical and pathological findings. So cotton wool spots, describing the pathophysiology and the differential diagnosis for cotton wool spots, the anterior segment manifestations of diabetes and the histological basis, and then describing the differences and the features of non-proliferative diabetic retinopathy and proliferative diabetic retinopathy, including the complications. There were 2 questions based on those. Then they talked about describing the pathogenesis and pathological changes involved in diabetic neuropathy. And lastly, cataract pathophysiology in terms of diabetes-induced cataract. They didn't ask any questions about incidence or treatment or any of the basic preparation or procedure sort of questions for diabetes. The common tasks were to discuss and to describe, and as mentioned, the common themes were pathogenesis and histology. Things not understood. So there's a lot of interchangeable terms that they sort of have when they say pathological changes. So I wasn't sure whether that actually referred to histology or the clinical manifestations. And in some of the model answers, they just provided both. So the clinical findings as well as histology findings when they're asking for pathological changes. And similarly for histologic basis, whether that's describing the histopathology. And a lot of the model answers gave the pathogenesis, so the genetics of it, and the pathophysiology and how that manifests as the histological manifestation as well. So my test question was discuss how diabetes can lead to diabetic neuropathies affecting the oculomotor nerves, including your discussion, the pathogenesis and pathological changes in the nerves. So the model answer was terrific. It discussed the different theories behind what causes a diabetic neuropathy, including the polyol pathway, the advanced glycosylation and products, and oxidative stress. It was very good in describing pathophysiology, but there wasn't much in terms of histology. So when they're asking for pathological changes, the model answer had good pathogenesis, but didn't actually describe exactly what you're looking at under the microscope. And the other interesting thing is that I couldn't find the answers to this question in the Eagles pathology textbook. So as a learning point, I think we have to be very focused on learning pathophysiology and histopathology and using the past paper questions to really study and use other resources apart from just Eagles. Would be my top tips based on diabetes.
Great, thank you, Shanil. That was a terrific analysis. You did a perfect analysis there with some key recommendations. So yes, Eagle doesn't have everything. Eagle is 2010 when it was written. So it's 10 years old now. So throwing it out to the group, what books have you found that are really good at pathogenesis, or resources, not just books?
So I found some of this pathogenesis was in Yanov. I found that quite useful for addressing that specific question.
So my Eagles is 2017, 3rd edition.
Oh, there's a 2017 edition, is there? Yeah. I've got the old one. Okay.
The online one is the new one as well.
All right.
I don't think it has much on diabetes, so does it?
No. Diabetic eyes tend to stay in their owners.
That's right. It's not a surgical problem.
Can I say iWiki? Is that bad?
My go-to for pathogenesis is usually iWiki too.
Okay.
It does good pathogenesis.
What about the AO? I didn't look at it.
AO book.
I don't think it covers it in detail.
I don't think the AO book the one that the volume 4 that I've got does great pathogenesis. It does like medium pathogenesis, but not.
I find that AAO is sometimes really heavy on studies and difficult to pull out the salient points for this topic.
So we're recommending Janov and iWiki. So going back to the previous slide, Chanel.
Right?
Yeah, so and one more, thanks.
All right, this one.
Yeah, so pathologic changes includes macro and micro, and macro includes what you see clinically with your eyes and with your instruments, as well as histologic slides. Yeah.
Okay.
And the histologic basis means histopathology.
Okay.
Yeah. Any other discussion?
Why do they use all these different terms, Diane? Why don't they just stick to the same word?
Wouldn't it be nice if people were terribly consistent? Don't get me started on granulomas and granulation tissue and.
Oh.
So just to clarify, Diane, histologic basis, histopathology is what you see under the microscope, or are you expected to talk about pathophysiology as well, the actual process that leads to that?
So shall we use it in a sentence? Okay. So usually when people talk about histologic basis, they talk about the reflection of the histopathology seen as a clinical sign. So describe the histologic basis of POAG. Okay, they would expect you to describe the histology that you would see in the angle, or the histologic basis of lattice dystrophy. They would expect you to relate what you see down the microscope in terms of what you see clinically.
Okay. Thank you.
Good discussion. Who's up next?
It's me.
It is Myers.
Yeah. So I'll share my screen. A second. Oh, it says failed, please try later. Let's try again.
Oh, Mark, I see you got a little star with you there.
Starting to run the study early. Just get the.
Can you
Yeah.
see?
You have to, that's right.
Can you see my screens?
Yeah, we can see your screen.
Sorry, I didn't realize that there was a format that I need to follow, but I've actually done a very similar stuff. So we will be just going through a very similar analysis to previous question, what I think is relevant. I call the glaucoma, it's a very big topic and it's commonly asked, I think it's usually asked once a year or so. And compared to the other topics, actually there's a lot to, in terms of mechanisms and correlating that to the clinical findings and to histopathology. But I think the good thing about glaucoma is that it's actually related to things that we normally see in our practices, and it's something that we can we have a basic understanding of the mechanisms already. We just have to formalize our ideas into a structured answer. So I'll just kick off. So I think the first thing I think is really important is actually to know the different, the classification of glaucoma, and to be very good at that and have it ready in your mind, how to differentiate the different types and what condition goes under what categories, because sometimes they ask simple questions and sometimes they actually trying to ask a differential diagnosis of an open or secondary open angle, or they give you a case scenario. So I think to start with, it's really good to know what would you classify as secondary angle closure glaucoma, for example, or secondary open angle glaucoma, and then have a basic understanding of those different mechanisms under each one of these categories. So what's happening? So if I'll just go to the questions, the things that they ask about. So for example, for the congenital glaucoma, you have to have a basic understanding of the genetics, as well as the clinical picture, and the mechanisms. The mechanisms, basically the fetal mechanism, like the configuration of the iris, of the angle, and understand how it looks like in the slide. I'm sure they will talk about this later, and then correlate that with clinical finding. It's usually the congenital has been asked for a while, but it's usually a very neat topic to be asked because it's quite concise and easy to answer. For the open angle glaucoma, the main question that it was asked, I think 2015, was about basically the optic nerve finding, optic nerve head finding, and the damage to the optic nerve head and the retinal ganglion. And I don't think this was answered very well based on the examiner comment, but I have to refer back to the previous presentation on the. I've copy and paste some of those from the previous presentation, which I think are quite useful. So I don't want to reinvent the wheel. So basically, you have to have really good understanding of this topic, because this is what you will be asked in primary open angle glaucoma. Otherwise, there's not much in terms of mechanisms, but you need to understand the pathophysiology of the glaucomatous optic nerve. Now, this is a very commonly asked question, whether it's directly or in a case scenario. So in terms of the secondary open angle, you need to know, sometimes they ask you specifically about studio BXF, for example, or lens-related glaucoma. Sometimes they'll just ask you for things that could be the tubercular meshwork being obstructed by a blood or cell or debris or pigment. So you need to have a differential there ready to go, and knowing what to write in each one of these subcategory of secondary open angle glaucoma. For example, for the PXF, you need to know the mechanisms of the PXF itself, how it affects the angle, how it affects the pigment epithelial, and I'm sure that will be covered next. And then know that it's subcategory of the debris, and then correlate that to the clinical picture. Same for the PDS, which I think actually, for me, if you see a slide, for example, I think the first thing we need to look at is whether it's open or closed. If it's open, I think the easiest one to pick up is actually PTS, because it's quite pigmented. There's a defect in the iris, and again, you need to know the mechanisms of that, and as well as the clinical picture and histopathology, which are all actually linked together. And the lens related, it's a very commonly asked question, either in a case scenario like this, when they give you a mature cataract and a previous trauma, and they want you to talk about the different types, or they can actually ask you directly if there's the type of glaucoma that are lens related, or where the lens plays a pivotal part. I think that was exactly how it was mentioned. So you need to know about the different types of DAOs and the mechanism of these different types. And for example, the type 3 hypersensitivity reaction, phacoantigenic, or the phacolytic, or the phacomorphic, which is basically an angle closure glaucoma. Same for the trauma related, which can go back to this question, because there was a trauma in this case. You need to have an understanding of the angular recession, the mechanism of angular recession, and the gosal glaucoma, as well as epithelial ingrowth, and have a good understanding of how they look like on the slides, because once you see them once, you remember how they look like, and they could look. You need to know how the different macrophages look like to be comfortable. A primary angle, I think we all know about that. So we, as I said, is against mechanism and angle closure, and then correlate that to the finding on the slides, an atrophic iris, for example. And you basically, this previous question just briefly discussed in the pathology of primary angle. There's one question I understand when they ask about the different mechanisms, but I think they refer to the relative and complete pluripoc, or maybe the phacomorphic, and that leaves us to the secondary angle closure. Again, you need to have a good list of what you want to write on that, or which disease you want to discuss on that. You can include the neovascular glaucoma, phacomorphic, whether it's actually secondary or not, I don't think it is, or you can call lens material, or posterior segment tumors. Yeah, I think that's about it. So it's a big topic, but the good thing is that it's actually things that we already know clinically, and which I think my advice will be to actually have a good understanding of how we want to differentiate the different types of glaucoma, and have a good understanding of the mechanisms, I would say.
Good. So that was what I got out of it too. Your top tips seem to be, have a good classification, understand the pathogenesis of the primary changes in glaucoma and the secondary changes in glaucoma. So concentrate on pathogenesis, and then concentrate on histopathologic appearances.
Yeah, which I think they are actually all linked. Like once you understand the mechanism, then you can find those things on the histopathology and they start making sense.
Okay.
Thank
From
you.
the floor, including our youngest member. We're all good? Straight on to the slides. Okay, so right, we've got a couple of slides there. Remember, when we're looking at these ones, again, low power observations are really, really important. Specifically, note the changes in the anterior and posterior eye, and then give your differential and preferred diagnosis. Okay, so I will put everyone into breakout rooms again. Okay, and we will have a go. Let's do this. Ten minutes. Okay, we're all coming back now, and I have started the recording again as we discuss this slide. Okay. How did you all find that one?
Interesting.
Yeah.
Okay.
From tumours, isn't it?
And interesting.
John and I just about got to the right answer when he pointed out the diagnosis on the URL.
Yeah, that's right. Yeah. Diagnosis isn't a secret. It's the trick of making the right observations, because if you make the right observations, you'll get the right diagnosis. Does anyone have trouble seeing what they thought they should be seeing, given that it was a neovascular glaucoma?
We were trying to find features of proliferative diabetic disease, and we found it hard to find those features looking at the retina.
So that there weren't any, but good looking. Okay, so if the iris isn't vacuolated, then maybe it's not there. And So that, as you know, clinically, the best place to find new vessels is probably around the disc. And if you just zoom around the retina at medium, not high power, usually you can see the vessels on top of the disc. I think I included a really good one in the diabetic Kura cloud cases, so you'll be able to see some really good diabetic stuff happening there. So it was relatively straightforward, wasn't it? So one thing I just wanted to go over was the low power bits. So where are we? Here we go. So can we make this bigger? Yes, we can. Okay, so we can make it bigger, and I will share screen.
There's a couple of questions in the chat thing too. So,
Oh, good.
Yep.
Right, hang on, I'm just gonna.
Yeah.
There, it's all. You can see like all my things open, and it's kind of. Where are we? Where are we? Where are we? We've gone. We've gone. Here we go. Right, there we go. Okay, so at low power, you can make it full screen, and then it becomes much easier to see that. In fact, even at low power, you can see that these angles are closed. Okay, so this is where the ciliary body is, the scleral spare. We should be having the angle back here, and it's definitely closed. Now the lens is a bit weird as well. This lens is not normal. It's got lots of cataractus change in it too. So we've got all this globule formation. Yeah.
Can you zoom in a bit on the globules?
Absolutely. So I'll just zoom in a minute. I'll just do
okay.
a scan. There's nothing underneath this retina between it and the choroid, which suggests, sorry, my mouse is like super sensitive, which suggests that this is artifactually separated at low power, and we can see the cup, which is really great. You probably all enjoyed looking at this nice angle, which is just perfect for neovascular glaucoma. Remember to mention the ironing board iris, okay, the flat surface to the iris, which suggests that there's rubeosis, even if you can't see stuff there. And notice the way that the iris epithelium is starting to curl around the tip here of this iris leaflet. Now, where should it stop? Where's normal? Just think clinically, do you often see it curling round the side? No, so this is the start of ectropion, isn't it? The other thing that I wondered if people were missing were here and here. So here we've previously had a posterior synechii. There's only one way to get pigment on the iris here, and that's previously, sorry, on the lens here, and that's previously if it's touched. Okay, so that would be a good notice thing to do. Let's have a look. This lens structure is not normal. Normally, as you know, we have a cortex and a core, but it's full of these little globules, and this is lens degeneration. You can see them quite nicely here anteriorly.
Oh,
I know, where you can see the lens capsule, and then this globule formation, which is cataractus change. So those are some other features that you might want to comment on. Right, what's in the chat box, Amanda?
Oops, even I can't see it now. There's questions about hemorrhage versus neovascularization. So that was from John.
Hemorrhage versus neovascularization. Okay, so there is clearly hemorrhage here, and the presence of hemorrhage suggests neovascularization quite strongly, because it would be very unusual to get hemorrhage around the optic nerve without neovascularization. But the new vessels are just about impossible to see. You can kind of suspect there might be some lying on the surface here of the optic nerve. So I've been advising people that if you can't see them, but you're really sure they might be there, and you can kind of see round outlines, then write suspicious for neovascularization. Just be a bit suspicious, and then they know that you've thought about it. The retina here, as I scan around, I could see no diabetic changes, and this is the kind of magnification that I would scan the retina at, because if we're going to show you stuff, we're going to give you a good picture of it. Any other questions there?
What about, Mark's asking, was the inferior retinal and choroidal detachment real or artifactual?
Okay, so it was all artifactual. If we zoom in here, we can see that the photoreceptors are intact. Just needs to, you see, I have trouble sometimes. I think it's not rendering, but the photoreceptors will be intact if there is a, if it's just been pulled off. And similarly, this choro, there's no reason why it should have pulled off. It just has.
It's a nice clear space too, with nothing in it.
Nothing in it, yeah.
Which makes me think artifact. So was there inner retinal atrophy?
Yes, so there was lots and lots of loss of ganglion cells. Oh, look, it just...
Oh, it's come. Oh, it's gone.
Yes, so there was massive loss of ganglion cells. So inner retinal atrophy also includes thinning of the nerve fiber layer. Look, I have trouble with that myself, deciding whether it's thin or not. I just comment on the absence or presence of ganglion cells. But here we can see that the photoreceptors are in fact intact. What are these white blobs? There's a bit of edema here. I think that's just random. Often we get these in our old collections post-mortem, and there's a little bit of post-mortem change sometimes. But
is there lacy vacuolization present?
I did not think so. I thought that the iris did not show lacy vacuolization. No, I'm just going to go
Have
a look at the iris.
Where would we see that, and what would that look like?
Okay, so it's got a few tiny holes in it. So what is lacy vacuolation? Lacy vacuolation is glycogen accumulating in the retinal pigment epithelium, and there's a few holes, right, but it's not a lot. So there's a minor amount of glycogen accumulation in the retinal pigment epithelium, not enough to be diagnostic. This shot also shows the nice new vessels on the front of the ironing board iris, as opposed to the deeper, bigger vessels. So this is what you see in neovascularization of the iris, just these little vessels on the anterior surface. And then,
is ironing board iris an accepted histopathological term, or should we say flattened anterior surface?
Yeah, of course, flattened anterior surface. You go ironing board iris.
Other questions? There's lots of questions, Diane.
Oh, good.
Yeah, was there DMO?
DMO?
Chanel? Do you want to...
Diabetic macular edema?
No, I don't think so. Yeah. So let's nip back to the macula, which was around here.
Or cotton wool spots?
I didn't think there was cotton wool spots or diabetic macular edema.
And Chris is asking, what's the best way? How do you know where to find the macula or
all right.
the fovea?
So what I do is I go to the optic nerve, and then I just go either side of it. So if you look up here, we're in the macula there, and it's either going to be either side of the optic nerve, because often they don't tell you which side we've got. And I just look for really thick outer nuclear layer, and that's generally where the macula is. And then we've got loss of the ganglion cells right through here.
Because Chris says there's no guarantee that the section will actually go through the fovea, of course. And
no, it like never goes through the fovea. Gosh.
No.
Yeah. So we just find the thickest bit adjacent to the optic nerve. This is just cutting through the edge of a vessel here. This bit.
Looks like smooth muscle. Can you comment on the underlying cause of the neovascular glaucoma?
So in this case, no, I couldn't tell what it was. So it's important when you're writing the description to say what's not there. So there were no convincing diabetic changes in this eye, really. There was only very minor lacy change, minor glycogen accumulation in the iris. There's no vascular changes that I can see. There's no non-proliferative retinopathy changes. And as we know, the differential diagnosis will include, CRVO and arterial occlusion. We actually can't tell in this eye, and that's not unusual.
Right. Whew, that was a good discussion. Anything else? They're all good questions. Lots of them, the answer is negative.
Yeah, so it's important to say what's not there in determining what we find.
Could be the pigment on the lens, could that be indication of, for example, uveitis or inflammation related?
Sorry, uveitis. So I couldn't see any uveitis present, and it's kind of weak evidence. I think we just observe it and note that there's no strong evidence of a cause. Okay, ready for the next round? Yep, I will pause recording. Okay, so we're coming back together. That was another great slide, wasn't it? Yeah. I'm so lucky to have these online.
Yeah, I can't imagine how you would practice otherwise, because the textbook just doesn't really, it's not the same because all the answers are right there, and you do want to test yourself a little.
Okay, I'm going to, right, so I've started recording again. And should I do this one as well, Amanda?
Yes, you're our non-plastic expert.
Yeah. Okay, so Amanda is now manning the chat for you to
I
ask.
will, yes.
So ask questions directly as well.
Yeah.
I'll just start doing a bit of screen sharing while that happens. Okay, questions from the team. Off we go. Forgive my dodgy navigation, as always. Any questions, Amanda?
Oh, not yet. So
Right, start whipping through the thing. So the URL said phacolytic glaucoma, and indeed we can see starting at the front that it looks pretty normal here with the cornea. The angles are open. The iris is nicely corrugated, but coming to the lens. So the lens capsule looks really baggy, and then we've got the lens nucleus, and all around the outside we've got the cortex here breaking down. Okay, so baggy with breakdown, and I think the phacolytic glaucoma in the Kura Cloud set was the same. As we go around, we'll go around this way. You might have noticed incidentally here, we've got some, we've got little cysts in the retina here. So this is an incidental finding that we find in lots and lots of eyes. So cystoid retinal degeneration at the peripheral retina is common. Looking around here, some of you might have seen these little things here. So this eye had a couple of drusen in, and I'll go back and have a look at that. Moving towards the back of the eye, we've kind of got the hint of maybe an early cup, but it's not very well developed. What we do have though is a really straight profile backwards here from where the nerve goes through the lamina cribrosa here, and we do have a bit of increased gap here between the nerve and the meninges. So we suspect that this is phacolytic glaucoma with some early cupping. So let's whip down to the front. Any questions yet, Amanda?
oh yes, good. So lots of questions. Let's just go for the low power questions first. Is there a way to tell artifactual capsular breach versus an in vivo capsular breach?
The capsule's really tough and strong, and
in fact, yeah. Is it breached at all?
Yeah, that's a good question. So it often leaks out through an intact capsule.
Ah, okay.
It just sort of looks baggy and wrinkled to me, like it's.
It does, yeah.
So that break anteriorly is probably just artifactual.
Yes, it is, yeah.
Yeah. And are there differentials to look for when it clearly looks like phacolytic?
Well, I guess phacoanaphylactic is your big differential diagnosis. So in phacoanaphylactic, usually there's a mature cataract, and you're dealing with granulomatous inflammation, particularly along the anterior part of the lens here. The angles can just have macrophages in, like before, like it is now.
Okay.
have done that inappropriate zoom again. I just tapped my mouse. Right, anything else from low power?
All right, that's all. We've got some
All right,
high power ones for later.
Yeah, okay. So you all saw these lovely, lovely, lovely macrophages. Yeah, they were gorgeous, these macrophages. Big fluffy macrophages that contain the lens material. And if you look carefully, you can also see lens material here in the trabecular meshwork. So it's got fluffy stuff through here. Now the Schlemm is back here, scleral spur. The ciliary body here shows some really nice hyalinization. So this is an age-related change. If you're under 30, then you probably don't have this. Mine will be well developed.
How can you tell, Diane, that these are macrophages? Why isn't it just fluffy bits of lens, degenerate lens material by itself?
Good question, because they've got a nucleus in the middle. So here we go. We've got a ring of fluffy material around a nucleus, and that means it's a macrophage.
So that nucleus is that little dot there?
Yeah, that's the one.
Okay. Can you show us the trabecular meshwork?
Sure. So this is the trabecular meshwork here.
Okay. And the canal of Schlemm again?
Is back here. These are the endothelial cells lining it here.
Okay.
Okay, so hyalinization just means dense collagen's laid down, and that happens in the ciliary body processes.
Here's another question. The iris root inferiorly looked hypercellular.
All right, so let's compare them. So the cellularity actually depends on the thickness of the section and whether or not there's inflammatory cells in it. Because the smooth muscle is of like uniform cellularity in real people. So if there's extra cells, you've got to think, is it a thick section or are there inflammatory cells? So let's nip across to the inferior iris root. Here we go. Right, that's better. And we'll wait for it to render.
And can you also point out the architectural features here, the trabecular meshwork and the canal of Schlemm?
Yeah, okay. So I think that probably, if there's any increase in cells, it will be lymphocytes, because they're little dotty ones. Okay, so there might be some little extra ones perhaps around, but there's not big clusters of them. I mean, that might be a lymphocyte, and that might be a lymphocyte.
Is that what you meant, Chris?
Often.
Yeah, just sort of like if you follow the dip of where the trabecular meshwork then joins the anterior surface of the iris, and then just kind of a little bit down from that in there. Yeah, pretty much where your mouse is now. Yeah, sort of in there. It just looked a little bit dense, but
I think there's some macrophages here too, because there's some pigment, and hey, how did that get there? Probably in the macrophage, and probably the macrophages with the fluffy lens material are also infiltrating here, and they've probably attracted a couple of lymphocytes.
Yeah, sure.
So I found this angle particularly troublesome, actually. So this is probably the trabecular meshwork, which isn't well seen, and I'm not quite sure what's happening here. The anatomy was more difficult.
It's got a bit of squash and then split, hasn't it?
Yeah, so this has got the quality of the trabecular meshwork, and I'm not quite sure what's happening here. This is like a vessel. I mean, if this was a wound, the start of a wound, I'd go, oh, this is new collagen. So I'm actually not sure what's happening there. That's a bit interesting.
And is some of that lens material like free floating? I can't see nuclei there in the angle, in the inferior angle.
Yeah, so there is just a bit of stuff like through here. It's just stuff. Yeah, through here.
Okay.
Flocculent's a good word to use. We often
Flocculent,
use it.
yeah, degenerate.
EXO, yeah. But
oh, it's also on the anterior iris, isn't it?
yeah, it's all the flocculent stuff, and macrophages on the anterior iris, like here as well.
Okay. There's another question. Are the clefts in the lens nucleus artifactual, or do they represent nuclear sclerosing cataract?
All right, so I think that they're artifactual.
Okay.
Often the lens just shatters as it's cut, and those look like shatter lines to me.
All right, and then we're up to sort of more high power questions.
Okay, off we go.
Or do you want to give us the higher power?
Okay, so we can see
Talking.
the little fovea here. So this is the edge of the fovea, and one of the interesting things about this eye is that the macular ganglion cells are really well preserved. So we haven't lost all the ganglion cells in this eye. We can see them when it renders. There's a nice thick layer here, but there is ganglion cell loss around the periphery. So this person still has vision at the center here. What else around here?
There's a question, is there, oh, I've lost it. It was John, I think, who asked about the nerve fiber layers at the optic nerve head there.
Yeah, I think they are slightly thin.
Yeah. Oh, Cam.
Yeah, it's pretty subtle, and if you're picking up that, you're aiming for the gold medal. So well done. But yes, it is slightly thinned here, I think. Yeah.
Can you show us where you would look in the peripheral retina for loss of the ganglion cells?
All right, let's pop out and have a look here. Let's have a look at these drusen because they're so cool well in the peripheral retina. Right, can you see them here as little humps here? I think humps underneath the RPE. These are the drusen. So it's very subtle, right? Because there aren't many ganglion cells out here, which is why I say please go and look at the macula for ganglion cells. But we've got, you know, 1, 2, and very few ganglion cells out here as we move along. And it renders just in front of me like a wave. Very few out here, ganglion cells.
So there's quite a difference, isn't there, between, so it's a comparative thing between the peripheral retina and the retina closer
so normally
to...
they're there, they're just more continuous line of them.
Mm.
And we can tell again that this is artifactual because the photoreceptors are looking great and there's nothing in the space here. All right, next question.
Good. And we've run out of questions at the moment.
Great, lovely.
Oh.
I will stop sharing.
That was a good session. Lots of questions make it more interesting. So we like questions.
Okay, we're going to